We're now going to talk about breathing patterns. So first we will talk about dyspnea, and we know dyspnea is the sensation of breathlessness as perceived by the patient. We've talked about dyspnea in the past. Orthopnea, which we mentioned earlier, is an abnormal condition in which a patient has difficulty breathing when lying down and has to use multiple pillows or sit to breathe. Let's just rewind real quick to dyspnea. Some symptoms associated with dyspnea include exaggerated respiratory effort by the patient, use of the accessory muscles of respiration, nasal flaring, and marked increases in the rate and depth of respirations. Next, we have wheezing. Wheezing is a high-pitched musical sound that is caused by high-velocity movement of air through a narrowed airway. And you can see to the right, this is a picture of the airway with an asthma patient. So at the top, we have a normal airway. You can see how patent and open that is. And below, we have the airway during an asthma attack. And you can see not only the excess mucus, but also the airway itself is extremely narrowed or tightened, making it difficult for the patient to breathe. And that's where we get that wheezing sound from, that high-pitched musical sound. It can also be present not just with asthma, but with bronchitis or pneumonia. It occurs on inspiration, expiration, or both. And we want to make sure that we determine any precipitating factors such as a respiratory infection, allergies, exercise, or stress. Next, we move on to a cough. Cough is a sudden, audible expulsion of air from the lungs. We've talked about a productive cough and a non-productive cough already. When we talk about a productive cough, we said that sputum would be produced. Sputum is generally a result from the sinuses draining, or it could be from the lungs themselves. Patients with chronic bronchitis generally produce sputum all day, although the body produces greater amounts after rising from a semi-recumbent or flat position. If a patient reports hemoptysis, which is bloody sputum, we want to determine the source. Generally, it's associated with coughing and bleeding from the upper respiratory tract, from sinus drainage, or from the gastrointestinal tract. We want to make sure that the patient is able to describe the hemoptysis if we are not a witness to it. We want to know the amount, the color, the duration of bleeding, meaning how long were they bleeding for or coughing up the blood, and any presence of sputum along with that blood. When hemoptysis develops, we want to note if the patient is on any anticoagulants or the medications that aid in thinning the blood. It is very important that we know this because if the patient is on anticoagulants or medications that thin the blood, there may be possible internal bleeding going on, and if they're coughing up blood, we will want to stop those anticoagulants as long as it's not severely contraindicated to prevent the patient from bleeding further. Next, we move on to respiratory infection. We want to determine if the patient had a pneumovax or flu vaccine in the past year. We would want to determine if the patient is on any immunomodulators or immunosuppressant therapy, or has asthma or COPD, because these patients are at higher risk of developing respiratory infections. We want to ask if they've had any exposure to tuberculosis. We also want to know if they have any intravenous drug use history, any blood transfusions, unprotected sex partners, homosexual lifestyles. Patients, particularly partaking in multiple unprotected sex partners or homosexual lifestyles are at greater risk for developing HIV-acquired immunodeficient syndrome or AIDS. Patients may not display any symptoms of HIV or AIDS infection until they have an opportunistic infection or present with vague complaints of fatigue and malaise. We also want to take into consideration our patients' medication use. We already talked about the use of anticoagulants. However, assessing their knowledge and ability to correctly take medications is also very important. We want to include how to properly prepare medications and how to properly take or administer medications. Reviewing this with the patient and having them repeat it back to us and demonstrate is very important in making sure that our patient is well taken care of once they leave our hands. We're now going to talk about more respiratory patterns, which may not be specifically listed in your text. However, you were given a handout and you are expected to have a general understanding of what these respiratory patterns are. Eupnea is a normal respirations that are quiet, effortless, and rhythmical. Tachypnea is an increased respiratory rate, so greater than 20 breaths per minute. Bradypnea is a decreased respiratory rate, which would be less than 12 breaths per minute. The normal respiratory rate is 12 to 20 breaths per minute. Kussmaul's respirations is a type of labored or hyperventilation which is characterized by consistently deep and rapid respiratory pattern. Causes of Kussmaul's could include or is often seen with late stages of a severe metabolic acidosis such as diabetic ketoacidosis. The patient will become very air hungry or struggling to breathe, and the desperate gasping characteristic of Kussmaul's breathing almost appears involuntary. Most of the time, a respiratory pattern secondary to a metabolic acidosis is rapid and shallow, and a true Kussmaul breathing pattern is rarely reached before the acidosis is corrected. Now on your handout, there is, under the Kussmaul breathing pattern, it says fruity acetone breath. A patient who has this labored hyperventilation also has a fruity smell to their breath, and that is because most of the times they are in diabetic ketoacidosis or DKA, which is a very severe condition with diabetic patients, and they have that fruity breath. The next respiratory pattern that we're going to talk about is Cheyne-Stokes. And Cheyne-Stokes is a respiratory pattern that is characterized by periods of respiration during which the tidal volume starts shallow and gets progressively deeper, and then gets progressively shallower. This shallow, deep, shallow pattern is followed by periods of significant apnea that can last up to 30 seconds or longer. Then the cycle starts over. Each cycle can take anywhere between 30 seconds or 2 minutes or longer. This pattern of respiration is often caused by strokes, traumatic brain injuries, brain tumors, carbon monoxide poisoning, and metabolic encephalopathy. This pattern of respiration can be seen in healthy patients experiencing first-time high-altitude sickness and can also be a normal side effect of morphine administration. And you can see in your picture on the handout that I gave you, it says stop and then a bunch of squiggly lines. So this is that shallow, deep, shallow pattern. It is often seen, as it says there, near-death breathing pattern because the patient is apneic for up to sometimes 30 seconds at a time. And as we can see here with the Cheyne-Stokes continuing on, it's waxing and waning with periods of apnea. And again, this is most seen during the end of life. And then we have agonal breathing. And agonal breathing is simply a gasping respiration. So if somebody is gasping, they would be considered to have agonal breathing or an agonal respiration. The link below will take you to different breath sounds, which we will review shortly. We're now going to talk about different breath sounds that you should be familiar with. The first is crackles, and you can have fine crackles or coarse crackles. Crackles are brief, discontinuous popping sounds that are high-pitched, and they are very similar to the sound of wood burning in a fireplace or cellophane being crumpled. You can also, if you have long hair, hold it in front of your ear and move the hair in between your thumb and your index finger, right in front of your ear. That is also an example of what crackles would sound like. Crackles used to be called rails, so you may hear the word rails used, but currently the word that is being used is crackles. This can be heard in inspiration or expiration. Generally, crackles are the hallmark of chronic bronchitis, but they can also be found with patients who have pneumonia, heart failure, or atelectasis. Then we have wheezing. Wheezes are adventitious lung sounds that are continuous with a musical quality. Wheezes can be high or low-pitched. High-pitched wheezes may have an auscultation sound similar to squeaking, and lower-pitched wheezes have a snoring or moaning quality. Wheezes can occur with both inspiration and expiration, and oftentimes correlate with some sort of degree of airway obstruction or narrowing of the airways, most often seen with asthma patients. Then we move on to rhonchi. Rhonchi are considered low-pitched wheezes. They are continuous, can occur on both inspiration and expiration, and they often have a snoring or gurgling, rattle-like quality, and these occur directly in the bronchi. Rhonchi usually clear after the patient coughs. The next slide will take you to a video listening to the lung sounds. It is very important that you are able to understand the definition of the breath sounds as well as be familiar with the sounds, because the sounds and the definition will be on your next test. So please keep this PowerPoint slide so you can continue to listen to the sounds over and over again, as well as the definitions of the adventitious or breath sounds. I happened to stumble upon this website, www.easyauscultation.com. It is an amazing site. Not only can you listen to breath sounds, there are quizzes on the breath sounds, so you will be given the sound and you have to determine which breath sound that is. But regarding vital signs, there is a whole tutorial on blood pressure readings, and you can practice listening to the blood pressure being taken, and you have to then obtain or enter the correct blood pressure reading. It is a wonderful resource, and I strongly encourage you to go to this website. Just play around a little bit. There are heart sounds, which we won't worry about just yet, but more importantly, there's the breathing sounds, the breath sounds, and blood pressure measurements that you can practice. So I strongly encourage you to go to this website. We're going to go a little bit more in depth into characteristics of sputum. So color is important. We all know clear is normal. Not normal would be like a greenish brown. That could be an indication of infection. White and yellow we want to keep a close eye on. Hemoptysis we talked about before is bright, dark red, or sputum that is streaked with blood or blood tinged. Also rust color would also be an example of hemoptysis. Presence of blood occasionally is okay. Usually early in the morning is when most sputum is coughed up by the patient, but if it's consistently happening, we may be a little concerned. To the right, that's a Lukens sample with a bloody specimen in there, and Lukens is just the way that the specimen is obtained. For example, if the patient is having nasotracheal suctioning performed, where we're sticking a suction catheter down into their trachea to remove contents within their lungs, it would go into the container to the right called a Lukens sample. Sputum, we then talk about the quantity. Quantity will vary depending on the patient's hydration or if there's any irritants that's causing them to cough up sputum. Consistency, watery sputum is normal. Frothy, tenacious, or viscous sputum is not normal. No odor is completely normal. Foul odor could indicate possible infection. Scant amount would be very small. That would be normal. Copious amounts, if the patient is filled with fluid or large amounts of sputum, we also use the word copious. To the right, you have a picture of sputum. Once we obtain a specimen, like in that Lukens sample, it is then prepared in the lab, put onto a slide, and examined under a microscope to see if there are any microorganisms growing. We're now moving on to the second part of the nursing process, diagnosis. Some nursing diagnosis that would be appropriate for a patient with cardiopulmonary issues would include activity intolerance, ineffective airway clearance, ineffective breathing pattern, decreased cardiac output, fatigue, impaired gas exchange, risk for infection, and acute pain. Patients with impaired oxygenation require nursing care plans that are patient-centered, and we need to direct them to meet their actual or potential oxygenation needs. When we talk about the third part of the nursing process, planning, we're going to talk about goals and outcomes, and we need to make sure that we're quantifying these subjective findings. So all goals need to have measurable outcomes for you to be able to determine whether they have been met. These include objective data, such as oxygen saturation levels, laboratory findings, chest x-rays, EKG patterns, blood pressure, and pulse. Quantify subjective findings, such as the reported degree of breathlessness or pain on visual analog scales, which are scales that the patients can point to determine their level of breathlessness or their level of pain. Patients generally have more than one nursing diagnosis, and often these diagnoses have an impact on one another. So we want to help the patient and family or caregiver set priorities for care based on the patient's tolerance. We want to base our decisions to delegate responsibility to nursing assistive personnel on our assessment of the patient and the type of care the patient will receive. Impaired levels of oxygenation affect all aspects of our patient's life, not just the physical component. Designing collaborative nursing interventions with physical and occupational therapy and social services improves your patient's level of functioning. Respiratory therapy helps to design measures to improve breathing and cough control. Social services are able to recommend support groups. When planning care for your patients with impaired oxygenation, be sensitive to the needs of both the patient and the family. This would be an example, and we're using Mr. King, who is in the book for the case study. So a nursing diagnosis that would be appropriate for him would be ineffective airway clearance related to pulmonary secretions. And our goal for him would be pulmonary secretions will return to baseline levels within 24 to 36 hours. And Mr. King's oxygen status will improve in 36 hours. And notice that there is a timeline associated with that goal. You always have to have a timeline associated with the goal. Possible expected outcomes for Mr. King include Mr. King's sputum will be clear, white, and thinner in consistency within 36 hours. Mr. King's lung sounds will be at baseline within 36 hours. Mr. King's respiratory rate will be between 16 and 24 breaths per minute within 24 hours. Mr. King will be able to clear airway secretions by coughing in 24 hours. Mr. King's SpO2, or pulse oximetry, will be greater than 85% within 24 hours. And actually, that's pretty low, but remember, he does have COPD, so that might not be too low for him. And lastly, Mr. King's perceptions of dyspnea will improve. The next step in the nursing process is implementation. So we want to make sure that we implement, especially for Mr. King, some healthy lifestyle techniques, such as healthy eating, exercising, resting, taking in fluids, so an increase in his fluid intake, and stopping smoking. Others include getting regular vaccinations and checkups to prevent illness. Specific airway management interventions for Mr. King include have him take deep breaths and cough every 2 hours while awake, have him change positions frequently if on bed rest. If able, have Mr. King ambulate 10 to 15 minutes every 8 hours and encourage him to sit up in a chair as often as he is able to tolerate. And lastly, encourage Mr. King to increase his fluid intake to 2,800 milliliters every 24 hours if his cardiac condition does not contraindicate it. Avoid caffeinated beverages and alcohol, and recommend water for Mr. King. We are going to continue the implementation portion of the nursing process and talk about health promotion. So, the flu vaccine is very important for individuals to get. The flu is a viral infection. Over 220,000 people are admitted every year with the flu. It is recommended for children 6 months and older, people with chronic illnesses, those 50 years of age and older, pregnant women, and those working in the medical field. We do not give the influenza vaccine to people with an egg allergy, as the vaccine contains eggs. The pneumococcal vaccine is for pneumonia. This is recommended for adults over the age of 65 or those with chronic illnesses such as heart disease and diabetes. Environmental modifications include us avoiding secondhand smoke and counsel families who have smokers in the families. It is very important that even if those who are ill are not smoking, that they are not around individuals who do smoke, because it will affect their overall health status. Also, avoiding perfumes or colognes. Many facilities will not allow employees to wear perfumes or colognes because it can affect patients' respiratory status. We're still continuing on the nursing, within the nursing process, the implementation phase, and we're going to talk about management of dyspnea. Initial treatment will include stabilizing the patient and trying to identify the cause of the dyspnea before it gets worse. Bronchodilators may be used, and this allows us to open up the bronchioles to allow more airflow. Mucolytics may be used. Mucomist would be an example, and this helps loosen or clear secretions. Expectorants can be used. Robitussin is an example of an expectorant, and that allows us to get the mucus up and out. Anti-anxiety medications may be used, such as Xanax. Anti-anxiety medications allow the patient to relax because when being short of breath or dyspneic, patients very easily become anxious. Anti-inflammatory medications may also be used, such as steroids, to help decrease the inflammation or the narrowing of the bronchioles to allow more airflow. Oxygen therapy may also be used in the form of a nasal cannula, and there are other oxygen therapies which we'll review later in this presentation. Physical techniques can be used, such as breathing techniques or cough control, and psychosocial techniques, such as relaxation techniques, meditation, prayer, music therapy, whatever works for that particular patient. We are now continuing the implementation portion of the nursing process and talking about maintaining a patent airway, and this can be done through numerous coughing techniques. The first is the cough and deep breathing. So simply taking a deep breath and allowing a cough to occur. The next is a cascade cough, and a cascade cough is a slow deep breath and then perform a series of coughs while exhaling. This technique promotes airway clearance and a patent airway in patients with large volumes of sputum. So a cascade cough would be used for patients with large volumes of sputum. The next is a huff cough. The huff cough stimulates a natural cough reflex and is generally effective only for clearing central airways. You will see on the next slide a video of a huff cough. With practice, a patient inhales more air and is able to progress to the cascade cough. The quad cough you will also see in a few slides in a video. A quad cough is a technique that is for patients who do not have abdominal muscle control, for instance, a quadriplegic or those with a spinal cord injury. The quad cough allows an inward and upward push on the abdominal muscles toward the diaphragm, causing the patient to cough. Additionally, pursed lip breathing can be used. This is when the patient puckers their lips, and breathes in and out with their puckered lips. Diaphragmatic breathing can also be utilized, and this is deep breathing while maximizing the amount of oxygen going into the bloodstream. Again, continuing on the implementation portion of the nursing process and maintaining a patent airway. There are multiple suctioning techniques. We're first going to talk about the oropharyngeal and nasopharyngeal techniques. And these techniques are used to assist a patient who is able to cough but unable to clear their secretions. And we would use the yank hour, which top right is a picture of a yank hour, very similar to the suction apparatus that may be used while you're at the dentist. Oral tracheal or nasotracheal suctioning is when a patient is unable to cough and does not have an artificial airway. So we would have to do nasotracheal. We may have to do nasotracheal suctioning, which you can see to the bottom right is when we insert a catheter into the either mouth or the nares to go down into the trachea and suction the patient. Tracheal suctioning is when the patient does have an artificial airway, such as a trachea, so the hole in their neck, and we would insert a suction catheter through the trachea or the ET tube, endotracheal tube, to to remove secretions from the patient's trachea or lungs. Here are some examples of artificial airways. To the top left, we have an oral airway, and this helps prevent obstruction of the trachea by displacing the tongue into the oropharynx. This keeps the tongue in a normal position. The top right is an example of an endotracheal tube with closed suction setup. So for example, when I am suctioning a patient who has a trachea and that is on a ventilator, The entire system, when I go to suction them, is completely sterile. I do not need to wear sterile gloves while suctioning the patient. The bottom left is a picture of a trach. The bottom right is the complete trach setup, and we will be learning about this in lab starting next week. You will see more of this when you come back in the following weeks during your clinical rotation. The video on this slide shows inline suctioning for a tracheostomy patient. This is just to give you an idea of what it looks like. We will be learning to do suctioning through the tracheostomy in lab when you come back during your clinical rotation. Some patients require oxygen therapy to keep a healthy level of tissue oxygenation. The goal of oxygen therapy overall is to prevent or relieve hypoxia. Any patient with impaired tissue oxygenation benefits from controlled oxygen administration. Oxygen is a drug, and the 6 rights of medication administration also apply to oxygen administration. I know we did not review the 6 rights of medication administration yet, but it is important to know that you do need a physician's order to apply oxygen. However, if it is a life-threatening situation, you are able to administer oxygen if it does delay care of the patient. So again, there is an order that is required, the physician's order that is required for oxygen administration. However, if the issue is life-threatening and delay of care will occur if you do not provide oxygen to the patient immediately, you are able to do so using your nursing judgment. Oxygen is a highly combustible gas and fuels fire readily. Although it does not spontaneously burn or cause an explosion, it can easily cause a fire to ignite if it contacts a spark from a cigarette or electrical equipment. Within healthcare settings, oxygen tanks or permanent wall pipe system supplies oxygen to a patient's bedside. So a lot of times they'll have a tank in there or a permanent wall piped system that supplies oxygen directly to the patient's bedside. Nasal cannula, nasal catheter, face mask, and the mechanical ventilator are all ways to deliver oxygen to a patient. On page 820 in your textbook, table 30-8, there are examples of oxygen delivery systems such as those that I just named. Please be familiar with the different types of oxygen delivery systems. When home oxygen is necessary, it is usually delivered by nasal cannula. 3 types of oxygen systems are used: compressed oxygen, liquid oxygen, and oxygen concentrators. In the home, the major consideration is the oxygen delivery source. Patients requiring home oxygen need extensive teaching, including oxygen safety, regulation of the amount of oxygen, and how to use the prescribed home oxygen delivery system. The case coordinator or social worker usually assists with arranging for the home care nurse and oxygen vendor. This is a picture of nasal cannula. These are different pictures of different oxygen delivery systems. To the left we have a face mask. Top left corner. Top right corner is a non-rebreather mask. This delivers high concentrations of oxygen. Bottom left we have a Venturi mask. This delivers a precise high flow rate of oxygen, and Venturi masks are used specifically for COPD patients. This is an example of oxygen concentrators. They can deliver up to 35% oxygen therapy, and these oftentimes are found in patients' homes or in long-term care facilities at the bedside. Picture top left. This is a Pessamer cap, which is a cap that goes over a tracheostomy, and this is to allow the patient to speak. It allows them to have a voice. You may have seen before, if anybody has had a tracheostomy, if you've seen it maybe on TV, where they place their finger over the hole and occlude it, and that gives them that voice. This pessamer cap, or speaking valve, also does the same, serves the same purpose. Top right is just a picture of a patient on a ventilator. In top left, this is a larger picture of a full tracheostomy setup. The ability of a patient to mobilize pulmonary secretions is the difference between a short-term illness and a long recovery involving complications. Maintenance of adequate hydration promotes mucociliary clearance, the natural mechanism of the body for removing mucus and cellular debris from the respiratory tract. Humidification is necessary for patients receiving oxygen therapy at more than 4 liters per minute. So, if you have a patient who is ever receiving more than 4 liters of oxygen at a time, it is necessary to provide a humidifier. Humidification is a source for hospital-acquired infections because the moist environment supports the growth of pathogens, so beware. Nebulization uses the aerosol principle to suspend a maximum amount of water drops or particles of the desired size in inspired air. This type of therapy is often used to deliver medications. The airway is patent when the trachea, bronchi, and large airways are free from obstructions. We use 3 types of interventions to maintain a patent airway: coughing techniques, suctioning, and insertion of an artificial airway, as we've already discussed. Coughing maintains a patent airway by removing secretions from both the upper and lower airways. We evaluate cough effectiveness by sputum expectoration, a patient's report of swallowed sputum, or clearing of adventitious lung sounds. Types of coughing include the cascade cough, as we talked about before, the huff cough, and the quad cough. Nursing interventions to maintain or promote lung expansion include positioning, incentive spirometry, chest physiotherapy, and chest tube management. Frequent position changes are a simple and cost-effective method for reducing a patient's risk for pooled airway secretions and decreased chest wall expansion. The most effective position for patients with cardiopulmonary disease is the 45-degree semi-Fowler's position, using gravity to assist in lung expansion and reduce pressure from the abdomen on the diaphragm. Again, the most effective position for patients with cardiopulmonary disease is the 45-degree semi-Fowler's position, using gravity to assist in lung expansion and reduce pressure from the abdomen on the diaphragm. When positioning a patient with unilateral lung disease, such as pneumothorax or atelectasis, meaning it only occurs in one lung, position him or her with the healthy lung down. This promotes better perfusion of the healthy lung, improving oxygenation. In the presence of pulmonary abscess or hemorrhage, place the affected lung down to prevent drainage toward the healthy lung. Incentive spirometry is a method of encouraging voluntary deep breathing by providing visual feedback to patients about inspiratory volume. We did this demonstration in class the other day. It is also an effective method for promoting deep breathing to prevent or treat atelectasis in postoperative patients. Administration of pain medication before incentive spirometry helps a patient achieve deep breathing by reducing pain and splinting. There is no clinical benefit to using incentive spirometer in place of early ambulation. Encourage your post-operative patients to ambulate as soon as possible, especially to prevent deep vein thrombosis. Volume-oriented incentive spirometry devices have a bellows that rises to a predetermined volume by an inhaled breath. An achievement light or counter is used to provide feedback. Chest physiotherapy, or chest PT, mobilizes pulmonary secretions. Chest PT includes postural drainage, chest percussion, and vibration, followed by productive coughing or suctioning. Chest PT is for patients who produce more than 30 milliliters of sputum per day or have evidence of atelectasis by chest X-ray film. Postural drainage is the use of positioning techniques to drain secretions from specific segments of the lungs and bronchi into the trachea. Chest percussion involves striking the chest wall over the area of the lung being drained. You position each of your hands so that the fingers and thumb touch, cupping the hand. Percussion on the surface of the patient's chest wall sends waves of varying amplitude and frequency through the chest, changing the consistency and location of the sputum. Percussion is contraindicated in patients with bleeding disorders, osteoporosis, or fractured ribs. A chest tube is a catheter inserted through the rib cage into the pleural space to remove air and/or fluids from the pleural space and re-establish normal intrapleural and intrapulmonic pressures. Chest tubes promote lung expansion and drain fluid or air from the pleural cavity after chest surgery or chest trauma, and for pneumothorax, hemothorax, or an empyema. A pneumothorax is a collection of air or other gas in the pleural space. The gas causes the lung to collapse because it destroys the negative intrapleural pressure. A tension pneumothorax, or a complete collapse of the lung, is a medical emergency resulting from a simple pneumothorax. Air becomes trapped in the pleural cavity between the chest wall and the lung. The volume of trapped air increases with each inspiration and is unable to escape with expiration, causing increased pressure on the lung, heart, and blood vessels of the thorax. A large bore cannula or chest tube must be placed immediately to release the pressure. A hemothorax is an accumulation of blood in the pleural cavity between the parietal and visceral pleurae, usually as the result of trauma. It produces a counterpressure and prevents the lung from full expansion. In addition to pain and dyspnea, some signs and symptoms of hemothorax include shock and severe blood loss. Disposable chest drainage systems, such as the Thoraceal or Pleurovac chest drainage system, are a one-piece molded plastic unit that evacuates any volume of air or fluid with controlled suction. The first chamber in each system provides a water seal to prevent air from being drawn back into the pleural space. The second chamber collects fluid or blood. The third chamber is for suction, to facilitate removal of chest drainage and trapped air. The suction pressure causes gentle, continuous bubbling in the third chamber. Changing chest tubes is contraindicated when a patient is ambulating or being transported. It is necessary to handle the chest drainage unit carefully and maintain the drainage device below the patient's chest. If the tubing accidentally disconnects from the unit, instruct the patient to exhale as much as possible and cough. This allows the patient to rid the pleural space of as much air as possible. Quickly cleanse the tip of the tubing and reconnect the tubing to the unit. Clamping the chest tube is not recommended because it may result in a tension pneumothorax, which we said earlier was a life-threatening event. Removal of a chest tube requires patient preparation. An analgesic administered before removal helps to minimize discomfort and anxiety. Generally, the healthcare provider removes the tube and places occlusive petroleum gauze or Vaseline gauze dressing over the wound. We are now going to discuss non-invasive ventilation. Non-invasive ventilation maintains positive airway pressure and improves alveolar ventilation without the need for an artificial airway. In addition, this mechanical ventilation alternative reduces and reverses atelectasis, improves oxygenation, reduces pulmonary edema, and improves cardiac function. Positive airway pressure keeps the terminal airways, or the alveoli, partially inflated, reducing the risk for atelectasis. Continuous positive airway pressure, or CPAP, has been available for many years and maintains a steady stream of pressure throughout the patient's breathing cycle. It is very beneficial to a patient with sleep apnea. Bi-level positive airway pressure, or BiPAP, works by providing assistance during inspiration and preventing airway closure during expiration. It provides two levels of pressure: inspiratory positive airway pressure and a lower expiratory positive airway pressure. The goals of non-invasive ventilation include improved ventilation and improved ventilation and sleep, enhanced quality of life, reduction of morbidity, improvement of physical and physiological function, and cost effectiveness. The American Heart Association publishes guidelines for cardiopulmonary care and resuscitation every 5 years. The organization outlines the standards for acute myocardial infarction, acute stroke, near-fatal asthma, anaphylaxis, and cardiopulmonary arrest for children and adults. A cardiac arrest is a sudden cessation of cardiac output and circulation. When this occurs, the tissues do not receive oxygen. Carbon dioxide is not transported from tissues. Tissue metabolism becomes anaerobic, and metabolic and respiratory acidosis occur. Permanent heart, brain, and other tissue damage occurs within 4 to 6 minutes. If you determine that the patient has experienced a cardiac arrest, begin cardiopulmonary resuscitation, or CPR. CPR is a basic emergency procedure of artificial respiration and manual external cardiac massage. The sequence for CPR is CAB: chest compression, early defibrillation, establishing an airway, and rescue breathing. Defibrillation is recommended within 5 minutes for an out-of-hospital sudden cardiac arrest, and within 3 minutes for an in-hospital victim. The recommendation further states that in addition to healthcare providers, specific lay individuals, police, firefighters, security, personnel, ski patrol members, ferry boat crews, and airline flight attendants need training in CPR and the use of an automated external defibrillator. You can refer to box 30-13 for more information on an automated external defibrillator, or AED. The recommendation is to deliver chest compressions for 2 minutes in a child and then call 911. For adult victims, the recommendation is to call 911 if you are alone, unless they have been involved in a drowning, drug overdose, or trauma. In these cases, begin chest compressions immediately. The rate of compressions for an adult, child, or infant is at least 100 compressions per minute. The ratio of compressions to breaths in 1 and 2 rescuer CPR for people 8 years or older, and for 1 rescuer child or infant is 30 compressions to 2 ventilations. So let me repeat that. The ratio of compressions to breaths in 1 and 2 rescuer CPR for people 8 years or older, and for 1 rescuer child or infant is 30 compressions to 2 breaths, so 30 to 2. You use a ratio of 15 compressions to 2 ventilations in infant and child 2 rescuer CPR. When you cannot establish an airway, reassess proper head position and assess for airway obstruction. The 2010 guidelines for CPR do not recommend that lay rescuers performed blind sweeps of the mouth or abdominal thrusts. We are now concluding the presentation and coming to the last phase of the nursing process, evaluation. With our patient care, we want to compare the patient progress to our goals and our outcomes, and we would need to modify the plan as needed. We would notify the healthcare provider if the patient's oxygenation declines, and we also want to make sure that we are aware of the patient's expectations and that they are ready to learn. Some general safety guidelines include the following. Patients with sudden changes in their vital signs, level of consciousness, or behavior are possibly experiencing profound hypoxia. Perform tracheal suctioning before pharyngeal suctioning whenever possible. Use caution when suctioning patients with a head injury. The routine use of normal saline instillation into the airway before endotracheal and tracheostomy suctioning is not recommended. And check your institutional policy before stripping or milking chest tubes. This concludes the Chapter 30 Oxygenation PowerPoint presentation for Fundamentals of Nursing 1 in Delaware County Technical Schools LPN program.